Good morning or good afternoon, wherever you might be. Welcome and thanks for joining us for the American Kinesiology Association webinar entitled Kinesiology and Public Health with Dr. Harold W. Bill Cole, Professor of Epidemiology and Kinesiology at the University of Texas Health Science Center, the Houston School of Public Health, and the University of Texas. My name is Tom Templin, and I am chair of the Communications Committee for AKA that is responsible for organizing these webinars, and I will be the facilitator for today's presentation. The webinar is scheduled for an hour and will be recorded and available for playback. By the end of the day tomorrow, you can expect an email from us containing the link to the recording. The link will also be available on our website under the announcements on the home page. All microphones and phone lines are muted, so we ask you to communicate with us using the GoToWebinar features. To submit questions, please type your questions into the question box located in the lower right-hand corner of your screen and click Send. We'll collect any questions sent throughout the presentation for Bill, and he will answer as many as possible during the Q&A segment at the end. Now I'd like to give you some background on Dr. Bill Cole. Bill is a professor, as I said, of epidemiology and kinesiology at the University of Texas Health Science Center, the Houston School of Public Health, and the University of Texas at Austin. Prior to this appointment, he served as a lead epidemiologist and team leader in physical activity and health branch of the Division of Nutrition and Physical Activity at the Centers for Disease Control and Prevention in Atlanta. He has worked since 1984 in the area of physical activity and health, including research, developing and evaluating intervention programs for adults and children, and developing and advising on policy issues. He earned his doctorate in epidemiology and community health studies at the University of Texas Houston Health Science Center, School of Public Health, and a Master's of Science in Public Health at the University of South Carolina. Dr. Cole's other areas of specialization are biostatistics and health promotion. His research interests include current focuses on physical activity, exercise, fitness and health, as well as in sports medicine surveillance systems for musculoskeletal injuries. In his recent efforts, he has concentrated on national and international physical activity surveillance and epidemiology issues, as well as program development and evaluation studies for the promotion of school-based physical activity for children and adolescents. He initiated Active Texas 2020, a state physical activity plan for Texas. He holds fellowships in the American College of Sports Medicine and the National Academy of Kinesiology. He is the founder and past president of the International Society for Physical Activity and Health as well. He is currently serving as chair of the Science Board of the U.S. President's Council on Physical Fitness, Sports, and Nutrition. Bill has published more than 180 papers, chapters, and monographs in the scientific literature, and in 2012 co-authored the textbook Foundations of Physical Activity in Public Health. Please welcome Bill Cole.
Well, Tom, thank you very much, and thanks to the American Kinesiology Association for hosting the webinar today. It's a topic for which I have considerable passion, and it's an honor to be here. So I do appreciate the opportunity. I have a really fundamental objective here in the next 45 minutes or so for the webinar, and that's to make the case that physical activity in public health, or public health specifically, should be considered a subdiscipline of kinesiology. It's a field that has grown and shifted and is splintered, and as Guy Newell has pointed out many years ago, an agenda of multiple agendas. I think that what I'd like to leave the people who join us today with, the idea is that public health should be one of those agendas in kinesiology, and I hope to persuasively make that case regarding what we know and the population-based impacts of physical activity. Those of you who are on Twitter, I tweet from Bill Cole at Bill Cole, and the hashtag physical activity is oftentimes used. If you don't know what Twitter is, don't worry about that, but I think it's a really useful outlet for communications in our particular area. I bring greetings from Austin, Texas, where one of our key local sayings is "Keep Austin Weird." These women, actually, I did get their permission before I took their photo, so that they made sure I wasn't stalking them or anything. But it's a nice place to be here in Austin. So 3 things I want to try to accomplish today: make the case of the number 1, make the case of the evolution of physical activity in public health as a identifiable subdiscipline within kinesiology. Second, point out what we know in a slightly maybe different way, that physical inactivity is an urgent public health problem. The intersection between kinesiology, if you agree that the center of the kinesiology universe is physical activity, then this becomes an issue that kinesiology needs to help address, as well as public health and other sectors. And then some ideas about the way forward for kinesiology in public health. Many people on the call are in academic settings where we train undergraduates and graduates and so forth in kinesiology, the various subdisciplines. I'd like to present, I don't like to complain without presenting some possible solutions and a way forward, and that's what the final third of the presentation will be today. Let's get started. This is how we do things in Austin, where the cars are shrinking and the cows or the steers are getting bigger. One key issue that I'd like to get across early on, and oftentimes it gets lost in some discussions when we talk about health, is the distinction between health and public health. And really what I am trying to communicate and address today is public health as it relates to kinesiology. The World Health Organization, there's many definitions. The World Health Organization, I think, has presented a useful one: a dynamic state of complete physical, mental, spiritual, social well-being, and not merely the absence of disease. Critically important here, the health in this particular context, and health as we see it, is at the individual level, not necessarily, in other words, the health of ourselves, our parents, our families, and so forth. Necessarily so. It defines what an individual's ideal health might actually be, but really lacks any understanding from a population standpoint of the difference between health and public health. In public health, I submit, the IOM is, the Institute of Medicine published this definition quite a while ago, and I like it a lot. Public health is that subset of health, or the broader view of health, that basically what we do as a society to collectively assure people can reach that state of health. It's a slightly different context, and oftentimes it's lost when people will come up to me and say, "Oh, we've been doing physical activity and health research for many years," and in fact, we actually have. We've been doing a lot of individual clinical work and training studies and a variety of things. It's helped us advance tremendously in this area, but less so in terms of the broader collective that is public health. And I think that that's a critical distinction, and one that we have to be thinking about when we address this idea of physical activity as a subdiscipline, or public health as a subdiscipline in kinesiology. What happens in public health? It's a very different kind of setting from many kinesiology departments. Certainly prevention of epidemics and the spread of disease, Ebola and other measles and other things of popular interest these days. It also protects against environmental hazards, injuries, encourages healthy behaviors, which is where we are, I think, in kinesiology, responds to disasters, assists recovery, and assures the quality and accessibility of health services. All these things, in general, have the populations that are targeted in mind, rather than simply only focusing on individuals. Clinical medicine focuses on individuals, important, critical. When you take a step back, though, public health looks at groups of individuals, populations that we are working with. And I submit that what we have learned in the last 40 or 50 years or so in terms of physical activity in public health presents a series of unique opportunities for us moving forward in kinesiology. So medicine addresses problems and saves lives one at a time. Public health addresses problems and is theoretically designed to save lives a million at a time. One of my favorite public health versus clinical medicine anecdotes lies in oral care, mental health care. All of us visit the dentists. Most of us brush our teeth most of the time. An important aspect of making sure you don't have tooth decay and other kinds of problems associated with it. Public health, on the other hand, addresses such a problem by promoting healthy behaviors, but also looking at more upstream things, fluoridation of water supplies, clean water, things like that, nutrition that promotes health or dental health in populations. So the idea between brushing your teeth daily and policies that encourage upstream changes such as fluoridation of water supplies is one of the best juxtapositions I can offer in terms of the difference between clinical approaches and public health. And in public health and physical activity, or in kinesiology and physical and public health, we need to be asking, where is our fluoride? Where is the upstream public health levers that can make physical activity a behavior that is accessible and can improve individual health while addressing it at the population level? I think that's the critical question that is driving me in my line of research, and has for the last couple decades now, I guess. So this is an interesting graphic that I think points out some of these things between public health and, in this case, primary care, individual medicine. Along the y-axis is implementation or practice versus all the way to planning and upstream kind of work. And on the x-axis is populations, groups of people, all the way to the individuals, going out to the right-hand side. And if you take a look at what each of these particular areas do: primary care management, managing disease, interdisciplinary care, rehabilitation, health and performance, individual health risk assessment, research into mechanisms at the individual level, all the things we're really quite used to, I think, in kinesiology, whether you're training students to go into cardiac rehab or into physical therapy, so forth. Very, very critical and important part of our work in growing the field. In public health, in the population level thing, the activities include more broad-based ones, such as population-based planning rather than individuals, population-based promotion, development of guidelines, whether it's physical activity guidelines or vaccination guidelines, things like that have the population in mind. Surveillance and epidemiology, health impact assessments, and so forth. And importantly, the things that I'm getting more interested in these days is system dynamics and thinking about how people live in a system rather than in a vacuum, if you will, and how those systems can work together and be linked across sectors. How does the transportation sector and the school sector, the education sector, and the parks and recreation sector work together to interdigitate the most optimal, for example, physical activity experience we're interested in. All those things are in the realm of public health. And in this intersection, I think, is where we have to be thinking about this in kinesiology and public health. planning for access to places to be active, evaluating outcomes, the effectiveness of behavior change and environmental change efforts, clinical counseling, health promotion, and importantly, finding ways to reduce disparities, both in access, in health status, and in other kinds of things. These kind of things drive both public health and clinical medicine. And these yellow, 5 yellow key areas, I think, are ripe for kinesiology and public health moving forward, bringing together the public health expertise as well as our individual or clinical expertise that we're used to in many aspects of kinesiology. So how do we get here? I think, and it doesn't magically start at 1900. Earlier on, there's evidence of the importance, obviously, all the way to Hippocrates, all the way back to Hippocrates, about the importance of exercise and health. But from a convenience standpoint, we can start at 1900, and we saw this evolution of separate and not really together advances in both public health science and in exercise science. Things such as disease control, public health science, understanding how to prevent transmission of diseases. Beginning in the late 1800s, the germ theory was finally accepted scientifically, and we had rapid advances in disease prevention and keeping people from getting ill, whether it's sanitation, safe water supplies, and a variety of other kind of things. At the same time, we begin to understand the role that exercise plays in as a perturbation in the body, lactate production, a variety of understanding of how CO2 is used, or how CO2 is expelled and oxygen is used, and so forth. Really, in the early part of the 20th century, some major advances were made during those particular times. Each evolved separately, though. And I think it's critical to understand that if we didn't have events in the 1950s coming together, we may still not be necessarily talking with each other with exercise science and public health science. In the early 1950s, we saw the appearance of our first set of population-based studies that were asking the question about the health effects of physical activity. And some of the groundbreaking work by Professor Jeremy Morris in London, taking a look at the health outcomes of London transport workers, comparing bus drivers who were sedentary all day with ticket takers in the very famous London route master buses here. The ticket takers walking up and down the stairs all day and making sure people had correct fare and so forth versus the drivers. And not surprisingly, it seems kind of straightforward these days, but not surprisingly, the drivers had a higher risk of heart disease, heart attack, severe heart attack, and mortality from heart disease compared to the drivers. And we were off and running then with those early findings that continued to pile up across cohorts, across particularly groups of workers, college alumni, and other kind of things. Some of the work that Ralph Paffenbarger and Jerry Morris did at the same time really helped elevate this discussion beyond exercise for performance issues. So in the 20-year period, for example, we had this thing going on in the area where there was a rapidly evolving science base that physical activity had something to do with health. It was hard to measure, and it remains to be that way. Health outcomes and computing power and others being what they were there, it was kind of the golden age of physical activity epidemiology. But it wasn't clear, the data weren't consistent necessarily, and we had to sort through that in that 20-year period of time. There were a lot of people starting to emerge, a lot of people who were passionate about fitness and about exercise, Jack LaLanne, Ken Cooper, others during this period of time, books and programs and the like, but the science behind the effectiveness of health-oriented fitness programs was still lacking. And so there was some confusion going on there how do we consolidate all this, and what was the truth, what was best for promoting health in this particular group. And then the other thing that I think that's overlaying this fascinatingly is it wasn't that long ago where people who were in cardiac, post-cardiac patients and others were told to bed rest. And turns out that's the totally opposite way we should be going with this. Is it really safe to suggest middle-aged and older people be active, given cardiac risks and other kinds of risks and so forth? So there was kind of almost a pushback about whether or not this was a kind of a unique and broad-based behavior that we could promote. Taking little, so that's kind of in the first 20 years or so, and then 75 to 95, we started to see the first research was advancing. We were going forward, I think, nicely in our laboratories and other kinds of areas with filling out what some of the missing information on physical activity and health, prompting popular professional associations to start issuing guidelines for their members. What do you do on exercise and testing and training? Or with people with a higher risk, trying to standardize what we knew in those particular areas, and also help stimulate research, what we knew and what we didn't know. The Heart Association, and they continue to do this. ACSM, most of the group on the call is probably familiar with this, and they continue to update these things. So we started in the mid to late 70s. We started to see the first professional guidance come in, but notice each of these, and those of you who have been around a while know that these are guidance for clinicians who have a patient who's sitting in front of them. What do you do if you're a ACSM certified exercise specialist and you've got an unhealthy, overweight, middle-aged man in front of you who wants to begin to exercise? How do you go about it safely so that that person can get the benefits? They were all focused on individuals, individuals with high risk of heart disease, high risk for its development, exercise testing, exercise prescription, and so forth. So we haven't quite made that leap from individuals to populations yet. If you take a look, for example, at the ACSM guidelines, here I haven't graphed them all. This is the first through the seventh updates. All of them focused on type, intensity, duration, and frequency of physical activity, things we're all quite familiar with. But interestingly, look at here what was going on in the first edition. The recommendation was for a 60 to 90% VO2 max. I'm going to have a hard time telling my mom what 60 to 90% of her VO2 max is if she wants to go out and take a walk. It's necessarily a very clinical approach. This is pretty intense exercise anyway, particularly for people who are unfit. And so this clinical approach to exercise prescription continues and begins in the mid-70s. Notice a change into the 90s, the next 20 years, the research was emerging. That lower end is bumping down a little bit. That's in response to evidence that studies were taking a look at the less vigorous, more moderate intensity of physical activity was starting to have some health. They're starting to show some health benefits as well. And then finally, we saw this emergence in the mid-90s of a caloric expenditure target in the guidelines, largely obviously in response to obesity problem that had been emerging for some years in the mid-90s. And it bumped it up here to 1,000 kilocalories a week in 2005. It maintains here the other updates I didn't graph. But you get the general picture here that it's a very individual clinical approach to exercise prescription as the times necessitated. 1990, I submit, is going to be historically a very important year for kinesiology and public health. In 1990, the ACSM position stand came out, and I remember this really quite well. And I'm going to read this because I think it makes my point specifically. Since 1978, an important distinction has been made between physical activity as it relates to health versus fitness. it's been pointed out that the quantity and quality of exercise needed to attain health-related benefits. Health-related benefits may differ from that recommended for fitness benefits. It's now clear that lower levels of physical activity than recommended by this position statement may reduce the risk of certain chronic degenerative diseases and yet may not be of sufficient quality or quantity to improve VO2 max. That's a major, I don't want to say concession, but it's a major acknowledgement by the ACSM, the world's largest professional exercise organization, that their guidelines may be too much. They may be too high in terms of the recommended quantity and quality of physical activity. And I think this, when this statement came out, this provided the necessary opening for this emergence of public health and physical activity. ACSM recognizes the potential health benefits of regular exercise performed more frequently for a longer period of time, but at a lower intensity than prescribed in this position statement. So this is, we're teetering here on not necessarily saying the old clinical approach to exercise prescription is wrong, but rather we're now opening up this opportunity based on research and emerging work over the years that in fact from a population standpoint we may need to be addressing the total spectrum and not necessarily what's important for improving fitness necessarily. Early 1990s, continuing this little jaunt, selective jaunt through history, more research coming out about this idea of accumulation of moderate intensity physical activity. Surveillance systems in the public health world suggested that only 10% were meeting those original vigorous physical activity standards of 20 minutes a day on most days of the week, or 20 minutes a day, 3 days a week we kind of grew up with in the training paradigm. I'm not a behavioral scientist, but those who know much more about it than I do were suggesting at the time that that vigorous standard, if it's all or none, if you can't do the vigorous 3 days a week, then why do it? Actually may be a barrier to many people, being more physically active, going for a walk after dinner and things like that. And then this aha moment where public health kind of got a seat at the table, I think, moving the entire population mean a little bit to the right in terms of the dose of physical activity or avoidance of sedentary behavior, if you will. Some of those first ideas came out. The whole population were to move, there would be major public health gains, not just selective in terms of training studies and others, but what can we do? Where's the fluoride, if you will, for physical activity in public health? Research continued to emerge. We started seeing these relationships with heart disease, stroke, diabetes, functional health status, falls, and the consistency with which these things were being described, I think, is remarkable in that more physical activity certainly seemed better for most particular outcomes. The patterns are a little bit different in terms of where the inflection point is in terms of the activity dose and the risk of disease going down or up, if you will. And importantly, an acknowledgement of the risks associated with physical activity. From a public health standpoint, just like every year we talk about vaccination status and the risks that might be associated with vaccines and other kind of things, we have to, anything that becomes a public health problem, we also have to understand from the population level what's going on in terms of adverse events. And obviously musculoskeletal injuries and sudden cardiac death are two things of key importance we have to do. And in fact, it's not a bed of roses. The higher the dose, we think, the higher the chances of adverse events, particularly in unfit individuals. Some other things emerging, I don't even have cancers on here, bone health, prevention of weight gain, assuming caloric, isocaloric status, presumably as activity increases, weight status, weight gain, prevention of weight gain increases as well. So you've got these emerging sets of evidence, all very consistent in terms of its approach. And it's not that much physical activity. It's not the people who run marathons or the people who are the elite athletes who are getting the benefit all the way up here in the upper ends. Very consistently, we see from many outcomes here in the lower end a dramatic drop in the risk of outcome given just a bit of a physical activity. And that gave a continued, I think, evidence, if you will, or fuel to the public health people to say this is really a public health issue and not necessarily a training issue. We saw emergence of the Surgeon General's report, the CDC ACSM recommendations in 1995, 96, Consensus Development Conference from NIH on physical activity and cardiovascular health. All of these were starting to emerge in the mid to late 90s, and I think it was really the time that physical activity and public health came of age, if you will, in terms of front and center. CDC ACSM recommendations: every adult American should accumulate at least 30 minutes of moderate to vigorous physical activity, and most preferably all days per week. Contrast this slide, which is the first CDC ACSM recommendation, or CDC ACSM recommendation for physical activity and public health, with those various issues, the various revision issues of the ACSM position stance. It's a lot easier to say this from a public health messaging standpoint than it is to try to get across 60 to 90% of your VO2 max or heart rate reserve or other kind of clinical exercise measures. And the evidence at the time supported this kind of recommendation. And we morphed into 2008, where we had our own standalone physical activity guidelines meant to be a companion piece to the U.S. dietary guidelines that talks about 150 minutes a week, at a minimum 150 minutes a week of moderate intensity physical activity each week. Really kind of a fascinating evolution, I think. And we had this exercise training paradigm, these early guidelines, and endurance exercise to enhance performance, particularly our focus on aerobic capacity. Training increases performance. And it's still valid. It's still a very good model to focus on. It may not be the most effective one from a public health standpoint. So the paradigm didn't necessarily get replaced. I think that we focused more on the fact that data from observational experimental studies suggested that moderate intensity activity accumulated throughout the day actually has some health benefits. And how do we turn that into a public health messaging approach and study it in populations rather than just individuals? So I think those 1990s, again, when history looks back in 50 years, 1990s, will be a seminal area where physical activity and public health really started to get a toehold in this area. So we had public health science, exercise science, the emergence in 1953 of population studies. We can't stop there, though, I think. Development of this field, we have to add things such as our understanding, really only in the early 90s, our understanding of behavioral approaches to physical activity. How can people change? How can we develop strategies to change people's physical activity behaviors rather than standing them on a treadmill and holding the treadmill for 30 minutes? How can we make this behaviorally appropriate? Some of the work that, some of the early work in this area, Bess Marcus and Abby King and others, Jim Salas, taking what we knew seemed to work from a tobacco smoking cessation standpoint and morphing it over into the behavioral science questions regarding physical activity have really helped our advance that field tremendously. And then even most recently, environment and policy. I think, again, Jim Salas and others have made it very clear, and in any public health issue, that environment and policy matters. Policies that don't support school physical education are not going to support any kind of physical activity. And so development of those policies and enforcement of those policies in the school-based setting are critical to keep physical education there. The built environment, city planning, renovations to neighborhoods and so forth, we're just now starting to understand. This is where our fluoride is, I think, and trying to take this field with its necessary and important base in public health science advances, exercise science advances, adding population-based work, what we know and will continue to discover in environment and policy and behavioral science is, I submit, the field of physical activity in public health, or kinesiology in public health. And as we go forward from into the middle of this current century, I think we'll continue to see these studies in these particular areas advance, and the field begin to grow stronger in this particular regard. So it's been a fascinating evolution, I think. Let's shift gears here quite a bit. Kim, I've got 10 minutes to go. I just saw a note from Kim that I have 10 minutes to go. This should be just fine. So this is a famous painting, Peter Bruegel, the elder, a Flemish painter in 1560. Very happy place where children are playing. From a public health standpoint, you couldn't ask for anything better. Lots of activity going on, social capital, if you will, and there might be some people fighting down here and so forth, but it conveys happiness and physical activity. And with the help of, with apologies to Peter Bruegel, as well as with the help of computer programs that can make some changes, I submit this is the current situation we're dealing with. The town square is empty. There might be one kid here who's stolen a loaf of bread or something, some fruit. The rest of the kids are up here on their computers and their televisions, and throughout the city there's no physical activity. We've engineered physical activity out of our daily lives. And thanks to Photoshop here, there's only one person who's actually getting any physical activity at all, presumably. What do we do about that? How do we make this a public health issue? And I submit there are many ways of doing that. I think asking the question, how can populations become healthier? We have to frame this issue as a public health problem. It's physical inactivity has been described as a pandemic here in a special series of The Lancet that we published a couple of years ago. When you usually think of pandemics in terms of Ebola and nasty things that are transmitted we can't see, or things like that. In fact, I think the case can be made quite easily that this is very much a pandemic in the world and has to be addressed with the same urgency as other problems. So you have to have three key things. Something has to be important, you have to know about prevalence and trends, and you got to present solutions for something to qualify as a public health problem. You can have it affect lots of people, but if you don't have solutions, you can't really do anything about it just yet. Maybe activities need to go on to some other thing that can be addressed much more easily. I submit that we have each of these three key areas in physical activity and public health, and it qualifies as a public health problem. One of the best papers that I've seen written on this is part of this in part of that Lancet series. It takes a look at trying to quantify the effects of physical activity globally on NCDs, and this is a terrific paper for you, your students, to try to do, to read and try to incorporate into your work. Essentially, what they try to do worldwide, taking worldwide prevalence data and other kind of things, estimate the percentage of deaths due to NCDs, heart disease, diabetes, breast and colon cancer, that could be attributed specifically to physical inactivity. And there's some strategies, ways to calculate this in the epidemiologist toolbox, in this particular case, population attributable fraction that takes relative risk and the prevalence, try to estimate what might happen if we magically were able to erase all physical inactivity. It's not just a mathematical exercise, it's a health policy question as well. And as you can see from this slide, the more conservative estimates adjusted for confounding variables in the red, the less conservative estimates that are unadjusted estimates, anywhere from 5 to 10% of heart disease in the world, heart disease deaths in the world, are estimated to be prevented if everyone were to magically become physically active and meeting physical activity guidelines. Diabetes, colon cancer, breast cancer, even all-cause mortality. really quite dramatic in this one kind of instance. Put it into perspective, estimate in terms of the number of deaths that might be attributed to physical inactivity each year in 2009, 5.3 million. Okay, that seems like a lot, but take a look at what has been estimated for smoking and what has been estimated for obesity. I'm not going to quibble about 300,000 deaths or so forth, especially given the way these calculations are made, but it's every bit as important as physical inactivity appears to be every bit as important a factor as smoking, and certainly more important in this particular case from a mortality standpoint than simply obesity. Physical inactivity goes beyond obesity. This is what kinesiology needs to focus on, I think, making this a public health problem. Physical inactivity could theoretically prevent 5.3 million deaths. And it's every bit as important as something we've been dumping millions and billions of dollars to, as necessarily we should, in terms of tobacco control. We should be doing the same amount of work in physical activity. Is it really a pandemic? Well, yes, it is. And again, we think of things such as bats and birds and things, and monkeys and so forth as transmitting diseases, or vectors of mosquitoes as vectors of diseases. It's a little bit different to think about physical inactivity as something that is pandemic, but not important necessarily for knowing the numbers in these particular, but globally in these particular maps, would graph the prevalence of people not meeting guidelines. What you need to know is red is bad, blue or white is no data, and the blue and the light purple are a little bit better. In terms of adults, in this case 15 years or older, 3 out of every 10 adult is not meeting guidelines based on global estimates, in-country estimates. When 3 out of 10 people in the U.S. were smoking some years ago, we had an all-hands-on-deck. We got to reduce that prevalence. Why aren't we addressing this problem like we have addressed other things such as smoking and nutrition? I submit we have to think about this in terms of a pandemic. Children, boys and girls, 13 to 15 years. If 80% of adolescents aged 13 to 15 years were smoking, what would be happening? There would be a worldwide mobilization, and as there should be. If you accept that smoking is or physical inactivity is every bit as important as smoking, we should have a worldwide mobilization to address this problem. And I can think of no more stark way to state that, is that if it's as every bit as important and it's more prevalent than smoking, we should be marshaling major attention and resources to this area. We know what to do. There are a series of evidence-based recommendations. We're actually in pretty good shape from a public health standpoint. The Guide to Community Preventive Services Task Force that's run from CDC has identified effective, promising, and even emerging strategies in 3 key areas that community-wide campaigns and things such as that. We have evidence that these things work. And we just need to put these ideas together and create this public health urgency that I think is needed to be able to shine a light on this area. Globally, I think it's that important. So we have prevalence and trends. We have magnitude and risk. We didn't even talk about indirect, economic costs and so forth. We know what to do. It is a urgent public health priority. Not just how to increase fitness in individuals or change people's individual behavior. We have to think collectively about what's the best way to make populations healthier, given these I think, numbers. So we've got these 3 things, I think, that are part of this problem. Way forward, briefly, as I'll end up here with, I think is kind of critical. What do you do with this? I think what we need to be thinking about is beyond behavioral science. I think we've got we've built this research on exercise science, public health science, behavioral science, environmental sciences. But the fundamental assumption that we're missing, I think, that health behavior equals public health is flawed. We've relied on behavior change theories. They're, I think, have taken us quite a bit away in helping us understand human behavior, particularly physical activity changes. And they have only taken us so far, I think. This is, we have to understand that public health requires an integration and an understanding of these interrelations. Not, and much like kinesiology, we talk about integrate over years. I think public health requires that, since it is not just how an individual's health emerges, but as the population health emerges. And we've written things such as a socioecologic model. I think importantly, we've written it far in terms of understanding individual health behaviors, but it doesn't help us much in understanding more population-based work. This is one of the famous, or one of my favorite quotes, and that's the whole concept of public health is founded on the insight that health and illness have causes or conditions that go beyond our biology or our physiology and beyond the behavior of the individual to the population. We always, I think, have to remain vigilant in understanding, when we're talking about public health issues, in understanding specifics to the population. And that's, if you don't take anything else away from the webinar today, that's one concept I'd like for you to take home. It's a complex behavior. And a complex behavior, I think, dictates going beyond individually adapted behavior change and acknowledging that it's nonlinear. This isn't something that's real easy to move forward from individuals to populations. There are interactions and behaviors. There are unintended consequences. How people adapt are different. There are competing actions working against people's intentions to be physically active. We have to make those acknowledgments, and in terms of a population level systems approach, we have to understand enablers and levels of influence, these other kind of things. And I believe it has the systems approach to this rather than an individual adapted behavior change. The acknowledgement that people live within systems has the highest potential to affect population level physical activity. This was a slide, a photo I took, the requisite, everyone's using the escalator stage, escalator rather than the stairs approach. This was taken at the 2012 annual meeting of the American College of Cardiology. And you can see how complex a behavior it is. Now surely all of these cardiologists are about to go for a run or already went for a run or a walk or so forth. And so they're okay. Even smart cardiologists, however, aren't part of this discussion yet in terms of approaches to physical activity. That's where I think we need to really focus on. So I think I'll leave it here. I want to make sure we have some time for questions. The take-homes here, I think, are absolutely critical for understanding physical activity and kinesiology in a public health setting. And one kind of thing I want to try to get across here, and we can talk about particularly with this audience, I believe that physical activity belongs in the, or public health belongs in the kinesiology constellation. We have exercise science, we have philosophy, history, sociology, behavior, motor learning and development, biomechanics. We have various these disciplines, we have various careers and so forth that people train for, PT, OT, athletic training, coaching, physical education and the like. They're all bound together by physical activity. That's kind of a given here. What's missing, I think, we have to be talking about is public health also. And there are jobs, there are careers, public health practice of physical activity that bring these kind of concepts together. And you in your departments, you in your work and other kind of areas, I would hope can be attuned to this idea that it's a population level problem and not just a problem at individuals, and make room in kinesiology for public health. Thanks so much.
Thank you, Bill. Really appreciate your willingness to provide this excellent webinar. I think we all probably learned a great deal here. Let me start the questioning by going to a comment that you made about public policy. As someone who's been involved in physical education for many years and certainly an advocate for physical education in our schools, I remain frustrated with public policy relative to the promotion of physical activity in our schools. And even in the presence of, initiatives from the White House or other groups that are advocates, I don't necessarily see a great translation oftentimes. And I wondered if you had exemplars or model kinds of states that have policies that could serve others well.
That's a great question, Tom. There are. We actually had some examples in just announce that there's a PDF report available from the Institute of Medicine it's entitled "Educating the Student Body," and it's all about making the school the hub for physical activity, helping kids get 60 minutes a day of physical activity, going beyond PE and others to creating these opportunities, the systems approach to physical activity. In there, detail state regulations and other kind of things. I can't pull them right off the top of my head, but they do vary. And in fact, there's a big push at the state level these days in many legislatures to go away from state level policy to local policy, and giving school districts guidance, many times no funding. Here in Texas, that's the case, but giving them guidance so that they might be able to enact their own policies. Now, I do believe that that's helpful, that's necessary. I don't think it's sufficient. I do believe that public policies can emanate from top down, and they should, but they also should come from the bottom up. And one of the most responsive ways, one of the ways that most principals and school district administrators will respond is responding to demand from parents, from concerned citizens, and who are interested in schools and in not only the health but the academic performance of children in schools. And so this mixture of an increased demand, having a parent ask, why isn't my child active 150 minutes a day in physical activity, or a week in schools, is an example of that ground up versus and meeting the top down, where there's a policy that can be implemented or staged or rolled out in sequence to be able to meet that demand. So I don't believe that public policy for this particular physical activity is all top down. I do believe that there's a way that we can, and we have examples of that. The whole smoking rights, non-smokers' rights movement from the late 1980s that started to help us get rid of smoking sections on airplanes and restaurants and so forth. I think it's a model for us to in physical activity to work with.
Great. Thank you. Clearly there are a lot of challenges here. Could you address your plea for perhaps or advocacy for perhaps a greater recognition of the role of public health and kinesiology? Do you see this happening in any of our institutes of higher education where kinesiology departments have given more attention to the importance of a public health perspective in their departments?
Yeah, it's varied, and I think probably some of the people on this call are more attuned to the individual department level things than I might be. I do know that this interdisciplinary work where you match whether it's someone in epidemiology or in some environmental health science or others in public health, with a group interested in exercise science or exercise physiology, specifically in kinesiology departments, can be a useful faculty model to follow. I do think that kinesiology is becoming such a wildly popular major that we have to be prepared to think about. Not everyone's going to go to PT school, and not everyone's going to go to be a personal trainer and things. And getting people, students, even undergraduate students, thinking and conducting research in this area that have thinking about problems at a population level applications. As I put here in this final slide, makes, I think, public health a very important part of this constellation. And we have faculties that have exercise science groups. We have biomechanists. We have people who are doing motor learning and development in kinesiology, behavior change, exercise psychology, even philosophy, history, and sociology. There's no reason that faculties cannot, in kinesiology, cannot be expanded to include people interested in population level work in public health. There are, I think, probably 4 programs now, exercise science programs or kinesiology departments, that are actually housed in schools of public health. That might make things a little bit easier, but I don't think you need that model necessarily to have to start to train students. I think there are programs such as Iowa and others that are expanding to include Iowa State to include public health as a key aspect of kinesiology.
Mm-hmm. Well, I'm pleased to announce that Purdue just hired a public health physical activity assistant professor who will start in the fall. So our institution is making some headway there.
That's a great step forward.
And I know that for those of you who didn't attend the American Kinesiology Association meeting in Charlotte, there was great advocacy for Bill's perspective position today. As many co-presenters reinforced Bill's message and provided additional data about the importance of the role of public health within kinesiology. So I want to thank Bill for your great presentation. I want to thank everyone for participating today. And if you would, please take a few moments when your webinar window closes to complete a short survey on today's webinar. We would really appreciate your feedback. It helps us continually improve our webinars. And if you have suggestions for future webinars for AKA, we would certainly be pleased to entertain those suggestions. We will email everyone a link to the recording of today's presentation so you can view it yourself or pass it along to your friends or colleagues. So thank you again for your participation today. And once again, thanks a million, Bill, for your message today, and it is much appreciated. So have a good afternoon, everyone, and thanks again. Bye.